Dear students and colleagues, the topic of presentation is infective endocarditis, and we will talk about the new guidelines about treatment and diagnostic infective endocarditis. Generally, infective endocarditis is caused by infection of the heart valve blood by fungi and bacteria and their vegetative growth, which consists mainly of platelets, microorganisms, and fibrins. The superficial growth can cause embolism in many organs such as kidney, lungs, skin, brain, central nervous system, leading to signs and symptoms. And it's very important that if patient with infective endocarditis doesn't receive adequate treatment, such patient can die and the disease can be lethal. Diagnosis of infective endocarditis at present moment is difficult, although blood culturing methods, accurate diagnostic criteria and echocardiography have improved, and we will talk about it. Clinical may also notice possible illness such as stroke, heart failure, pulmonary embolism, meningitis, nephritis, collagenoses, pneumonia, urinary tract infection due to the severity of symptom of infective endocarditis. The main diagnosis and steps for diagnosing of infective endocarditis you can see at this slide, and we start with the transthoracic echocardiography and examination of pathogens of heart valve. We do culture test, and if positive, can observe pathogen by gram stain or histological methods or molecular methods we can use in practice. And of course, bacteriemia can be associated with other situations and diseases as a periodontal disease, polymicrobial wound infection, and endocarditis. The main clinical symptoms of endocarditis are new or changing heart murmurs, and it's due to vegetations on valve. The second very important clinical manifestation can be fever, and all doctors should remember that if patient has a fever unknown origin, it's a main indication for echocardiography for excluding infective endocarditis. In patient can be splenomegaly and microembolic complications I talked about before. This is a new European recommendation on infective endocarditis, which changed previous and update previous 2015. Yes, and this new knowledge, they in 5 areas. First is that antibiotic prevention we do at high risk patients, and prevention measures for intermediate risk and high risk patients. I will talk about in the next slide. The second new, these recommendations that diagnose with emphasis on multimodality imaging to assess cardiac lesions of infective endocarditis. It's very important because just one echocardiography maybe not visualize vegetation on valves, and in this case we should use other more informative methods of examination and visualization. The third new is that antibiotic treatment allow an outpatient use antibiotics, but we can use it just in case of stabilization and in uncomplicated cases. The fourth, that cardiac surgery with emphasis on early intervention without delay for complicated cases. And the fifth, new position, and these guidelines that share management decision by the endocarditis team. And if shortly, infective endocarditis summarizing all data, you can see that prevention we do recommend just at case of high-risk patients, and we recommend general measures and antibiotic prophylaxis. For moderate risk patient, we recommend just general measures, and for low risk patient, we don't recommend anything. I wanted to emphasize that antibiotic prophylaxis we recommend just in case of high-risk patients. About diagnosis, of course, the basis is a clinic evaluation and blood culture. But plus, at present moment, we have a multimodality imaging of cardiac lesions. It's echocardiography plus, if inconclusive consider, we can use CT and nuclear medicine imaging in any case a difficult diagnose. Antibiotic therapy. What's the news? That possible of outpatient antibiotic therapy if a patient has no complication, stable, and if infective endocarditis caused by Staphylococcus aureus, Streptococcus, or Enterococcus faecalis. In this patient, if they have no fever more than 2 days, if they have decreased C-reactive protein less than 25% from maximum or less than 20 mg per liter, and white blood cells less than 15, at this case, we can recommend patient to continue antibiotic treatment ambulatory. And cardiac surgery. At present moment, we have 3 main indications as a heart failure. The second one is uncontrolled infection, and the third is prevention of embolization. At time of cardiac surgery, we have emergency indication within 24 hours, urgent within 3-5 days, and non-urgent surgical interventions. Who are at high risk of infective endocarditis? Of course, is a patient with a previous history of infective endocarditis. It's a patient with a surgically implanted prosthetic valve and any material used for cardiac valve repair. It's a patient with congenital heart disease at high risk for infective endocarditis in case of untreated congenital heart disease and those treated with prosthetic material. Patients with ventricular assist device as destination therapy. Again, for this patient, for prophylactic of infective endocarditis, we recommend general measures and antibiotics. In case of intermediate risk, who are these patients? It's a patients with rheumatic heart diseases, patients with non-rheumatic degenerative valve disease, patients with congenital valve abnormalities including bicuspid aortic valve, patients with implanted electronic devices, and patients with hypertrophic cardiomyopathy. All these patients, they need general measures for prophylactic of infective endocarditis. And low-risk patient, it's all other group of patient. What means general prevention measures for patient? And we do it in case of high and moderate risk. It's tooth cleaning twice daily with dental cleaning, twice early for high-risk patient and once early for intermediate risk patient. Strict cutaneous hygiene, disinfection of wounds, curative antibiotic therapy for any focus of bacterial infection, but with avoidance of self-medication with antibiotics. Just install control of doctor. Strict infection control measures for any at-risk procedure. Discouragement of piercing and tattooing, and limitation of infusion catheters and invasive procedure whenever possible, and strict care of balls for central and peripheral intravenous infusions. What's the indication for additional visualization methods? First line diagnosis is echocardiography, but if it's not enough informative, we can use computer tomography in case of diagnosis of infective endocarditis and perivalvular and periprostatic complications such as abscesses, pseudoaneurysm, fistula, detection of distant lesions and sources of bacteremia, pre-operative assessment of coronary anatomy, evaluation of alternative diagnosis. MRI, what the indications? Diagnosis of infective endocarditis and its cardiac complications. Diagnosis of neurological complications of infective endocarditis and diagnosis of spine lesions. And nuclear imaging, positron emission tomography, CT, and other we can use in case of diagnosis of infective endocarditis and its cardiac complications, detection of distant lesions and sources of bacteremia, and for monitoring response to antimicrobial treatment. We have a recommendation for empiric antibiotic therapy in infective endocarditis for adult patients with a class of recommendation 2A and 2B. In case of community-acquired native valve endocarditis or late prostatic valve endocarditis more than 12 months after cardiac surgery, targeted at staphylococci, streptococci, and enterococci. At this case, we recommend ampicillin with a ceftriaxone or flucloxacillin and gentamicin. Ampicillin 12 grams per day intravenously in 4 to 6 doses. Ceftriaxone 4 grams day intravenously or intramuscular in 2 doses. Flucloxacillin 12 grams per day intravenously in 4 or 2 to 6 doses, and gentamicin 3 mg per kg daily intravenously or intramuscular once daily. In case of early prostatic valve endocarditis, if it occurs less than 12 months before cardiac surgery, or if healthcare associated, which can be targeted at methicillin-resistant staphylococci, enterococci, gram-negative pathogen. At this case, we can recommend and use for treatment vancomycin or daptomycin combined with gentamicin and rifampicin. The dose should be vancomycin 30 mg per kg daily intravenously in 2 doses. Daptomycin 10 mg per kg daily intravenously once daily. Gentamicin 3 mg per kg daily intravenously or intramuscular once daily. And rifampicin 900 up to 1200 mg intravenously or orally in 2 to 3 doses. If patient has allergy to beta-lactams, we can recommend for community-acquired native valve endocarditis or late prostatic valve endocarditis, which can be targeted at staphylococci, streptococci, enterococci, cefazolin or vancomycin in combination with gentamicin. The doses for cefazolin 6 grams per day intravenously in 3 doses. Vancomycin 30 mg per kg daily intravenously in 2 doses. Gentamicin 3 mg per kg daily intravenously or intramuscular once daily. And the fifth position that new in guidelines 2023 for diagnosis and treatment infective endocarditis is that just endocarditis heart team, which consists of members from cardiologists, cardiac imaging experts, cardiovascular surgeons, infective disease specialists, and microbiologists, can improve prognosis patient with infective endocarditis. Thank you for attention.